Good morning. My name is Michael Ayers. I'm a fellow from the Hospital University of Pennsylvania. My family's from Texas, so it's a real pleasure to be back in warmer weather. Thank you to the panel and the Houston Shock Symposium directors for this honor. Forgive the rattle in my voice. My toddler blessed me with the daycare plague just before leaving. I'm sure an entity with which many of you are familiar. So the title of this case is Massive PE, Leave a Sheath Behind. We're going to be talking about the characteristics of acute right ventricular failure, cardiogenic shock, and PE, and then the mechanical and catheter-directed support options available. So this is a 60-year-old gentleman with a history of hypertension who's coming in with 3 days of dyspnea on exertion, limiting a good exercise tolerance to about 1 block with some associated pleuritic chest pain. No risk factors for clot, no heart failure symptomatology other than about 6 months of lower extremity edema. However, he turns to his wife at home and says, something is wrong. And he wasn't talking about their marriage. He had become even more short of breath. She calls the ambulance. The initial vitals, 1 teens, systolic 220s, but quickly plummets en route, and his systolics are in the 50s, 60s. When he arrives to Penn, narrow pulse pressure, he's hypotensive, he's tachycardic, he's tachypnic, he's hypoxic on room air. His blood pressure does upward trend over the first 2 hours with some fluids and some heparin from the 70s, 80s to the 90s, 100s, but he's uncomfortable, his neck veins are up, he's got a tricuspid regurgitation murmur, and importantly, he's cool to the touch. So unsurprisingly, while his basic labs are normal, he's got a profound AA gradient, he's acidemic with a lactate of 5. Interestingly, his tropes are within normal limits, NT-proBNP up from his baseline. He's bolused heparin, and his PTT is therapeutic within an hour, which is very important in this case. A retrospective look at our cohort from Penn shows that in the high, intermediate, and high-risk group, the people who do poorly tend to have one thing in common. Time to therapeutic PTT is prolonged. This is his EKG with a new right bundle, a Q wave in 3, T wave flattening in 3, consistent with sinus tach and right heart strain. We get some imaging. A limited echo, which is code for I was moonlighting and the attending said, come here and look at this. Bedside shows an RV that's moderately dilated, dysfunctional, relatively normal LV, but you'll have to believe me, there is a large serpiginous 8-centimeter clot that is slithering, to stick with the snake metaphor, back and forth in the RV and RA. The picture from my phone didn't turn up very well, but there it is. And unsurprisingly, he has bilateral PE. So we've got this 60-year-old man coming in with 3 days of dyspnea that acutely worsened today. He's tachycardic, tachypnic, hypoxic, acidemic, RV strain on echo with a large clot in transit. CTPE shows PE consistent with a high-risk PE, and if you were to plug him into a PESI score, it would say he's got a 25% mortality at 30 days. But when we retrospectively look at the high, intermediate, and high-risk group that have clot in transit, the mortality is probably upwards of 50% at 30 days. So, with that in mind, few people would say, let's just park him on heparin and we'll deal with it in the morning. In the right center, you could take him for you could take him for surgical embolectomy, depending on the center's preference, but he's not quite stable enough for that. You could certainly give him systemic thrombolysis. That would be a very reasonable option, or you could give him catheter-directed therapies. We have a pathway at Penn that's supposed to help us decide on these things, but we really treat these people as individuals, and this pathway falls apart very quickly. As you'll see, the first bifurcation is, was his systolic pressure greater or less than 90? Well, it depends on when you're talking about, arrival or 2 hours later. If it's less than 90, he's plugged in mechanical circulatory support systemic lytics. If he's greater than 90, we're talking about catheter-directed therapies. So what do? We take him to our OR suite, where very importantly we use MAC anesthesia. We do not induce these patients, as we've found that the induction frequently causes RV dynamic collapse and they go into arrest. We placed a 26 French gore dry seal in the right fem, and we angiovac. At the same time, we were going ahead and putting in sheaths for ECMO, but after sucking this out, it was all high fives and chest bumps in the lab. The guy was 120/80. He was asking for a sandwich. His heart rate had come down in the 90s. We were like, yeah. We left the sheaths in place, and we sent him to the CT SICU, where within hours, he developed 2-pressor shock and mixed hypercarbic hypoxic respiratory failure. At that point in time, we very calmly, through the sterilely placed sheaths, initiated VA ECMO, and we were left with another choice. What do? It would be reasonable to park this guy on heparin. He's supported on a VA ECMO platform. You could do systemic thrombolysis, but you're getting really out of data here, right? We've got VA ECMO cannula in place. He just had 26 French dry seal in the groin. You could do surgical embolectomy or, again, catheter-directed strategies. So we delivered 2 5 French infusion catheters, Craig McNamara, and we did catheter-directed thrombolysis. This is the pen pathway we use. They get an initial bolus. They get 1 mg per catheter for the first 6 hours, then 0.5 at the discretion of the provider. And we check for bleeding. We keep them lightly anticoagulated so that the infusion catheters don't clot. 30 to 40 minutes after the alteplase, we pull the venous sheaths and we do stat enoxaparin or heparin, depending on the trajectory of the patient. So he comes back to the CT SICU and within 6 hours has full pulsatility, pressors are off. He gets 24 milligrams of alteplase, which if you look at Seattle, Ultima, Perfect, those studies, that's a middle of the road dose in terms of total alteplase. Unsurprisingly, he has acute and chronic DVTs bilaterally. But by day 4, he's walking around, extubated, decannulated on room air. Day 7, we place a filter. And day 8, he's discharged on apixaban. We see all of our high, intermediate, and high-risk people at the PERT clinic, and his 6-week follow-up shows an RV that was mildly dilated but normal function. And lest we forget, we go back and get that IVC filter at 8 weeks. With that, I'm going to go ahead and stop because I think there's a bunch of interesting decision points in this case, and I'm sure a lot of people would have handled different moments differently. I just wanted to thank my mentor, Dr. Rame, for helping me with this case and many things in life, as well as all the people in the Penn PERT team. Thank you.
I have one question. The question I had is the patient had bilateral pulmonary emboli with RV strain, so the decision was taken to the cath lab and suck the clot out, which was there in the RA. But nothing was done specifically for the bilateral PE with RV strain by itself. That itself was hemodynamically unstable. I understand that the clot would prevent further PE and that would be a death knell for the patient, but I was curious on the decision.
Yeah, we review all of the high, intermediate, and high-risk cases as a group, and we've got about 6 to 8 patients that look very similar to this, 50s, 60s, really in shock on arrival. We take them, we go ahead and place sheaths for ECMO and do the angiovac, or we do embolectomy, catheter-directed embolectomy. And 4 of them recovered without any ECMO, and then 2 of them ended up like this. And so there's some disagreement in our group right now about whether or not we should just park these people on ECMO. Again, the number needed to harm on ECMO is often 20. So it's not an easy decision when you've got a decent number of these people that turn around just with heparin.
I have two questions, actually. One is, why take out a filter? Maybe they're more compliant in Philadelphia, but I'm not sure that a guy with this kind of thrombophilia will ever be off or be out of risk. And second is apixaban versus warfarin?
Excellent questions for both. And it depends on which PERT attending is on. There is about half that would send him out on warfarin and about half that would put him on a DOAC. Our group, our heme group, Dr. Suker, is pretty aggressive with the DOACs, and so when he participates in the PERT team, he's putting all these people on that, but it's an evidence-free question. And as for the filter, that's even more evidence-free, so I'm gonna...
Okay.
2 questions on regards to warfarin. I think our personal bias is time to therapeutic is 60%, compliance factors, this degree of clot burden, I don't think personally warfarin is a good choice. One can take the literature from oncological patients. Lovinox is a better option for some time, and then switch them to DOAC. That would be a better option.
Yeah.
You know, I'm a surgeon, but in this same case, what would be an absolute indication for surgery in your mind?
Christian Bermudez is the surgeon who participates on our PERT team, and that was my question for him actually when we met as a group. He agreed with the catheter-directed thrombolysis strategy once you'd stabilize them on the ECMO platform, and he said if he didn't see return of pulsatility within about 24 hours, he would favor a surgical approach.
My point that I want to make is I want to keep you away. There is one absolute indication. If you have an in-transit thrombus and you have a PFO, that patient is an absolute indication to go for surgery. No discussion for any other therapeutic option.
Absolutely.
And we do the same thing where these unstable patients, we have the sheets in before even taking to the cath lab. Perfusion team is aware. So we've been doing this PERT since we initiated. And I feel like as the VA ECMO programs mature around the country, the PERT protocol will be further tightened in terms of these surgical embolectomy decisions. And I would argue 24 hours for return to pulsatility may be too long. And as the PERT registry kind of matures as well, we will see the CTEF portion. So there has to be this idea that plumbing, angiovac, ecos go through. And in our program, Dr. Carr is a huge proponent of angiovac, plus bivalirudin in these patients. So we feel that bridging them, you do, and then in this case, I know lytics in terms of the dosing, all of those are gray areas, but we do believe that bivalirudin has been, and we need to build up the cases.
Yeah.
We put in our experience in the VAD journal like about maybe 5 years ago. But angiovac plus bival,
One of the
suggestion.
one of the disappointing outcomes of the Seattle Ultima Perfect catheter-directed thrombolysis cohorts was that CTEF was not reduced compared to the control arms versus surgical embolectomy, which shows that CTEF rates are reduced. So I think that's an important point, and as more data is accumulated, that'll become clearer.
That is exactly the reason. When you have a submassive or a massive PE, there are two components of that. One is the hemodynamic challenge to the right ventricle, which you're doing. And second is what happens when this clot breaks down and goes further distal. And that's where the VQ mismatch goes up. And to dissolve those later on is a big problem. That's why you have to be very aggressive up front. I think the decision to ECOS, not ECOS, angiovac was perfect at that time. But I think at the same time, if you put the lytics, which you did subsequently, you would have gained 12 hours or whatever time you took.
Right.
So you would have had a higher chance. And the more nascent the clot is, more vulnerable it is to lytics than if you give it 10 or 12 hours.
For me, looking back at this case, I probably would have pushed a little bit harder for catheter-directed thrombolysis at time of angiovac.